Good afternoon, everyone. Could you please press the thumbs up sign if you can hear me? Can hear me clearly? Okay, thank you very much. Good afternoon and welcome to the 6th webinar of the IMath Webinar series. So first, let me just remind everyone that this webinar is being recorded and it is being streamed live on YouTube, and the link is found as comment on the announcement of the webinar on the official IMath Facebook page. Okay, so again, I would like to welcome everyone. And our speaker for today is Mr. Yongsuk Ko of Konkuk University in Korea. And he will be speaking about mathematical modeling of COVID-19 pandemic in Korea, model-based analysis about the issues in 2021, vaccination, and Delta variant. So after the talk, we have time for some Q&A, so you can ask your questions, then you can raise your hand, you can unmute, or you can type it in the chat box. Okay, so again, let us all welcome Mr. Yongsuk Ko.
Hello, I'm Yongsuk Ko from Korea. So shall I?
Yes, you can feel free to share your slides.
Yes. Can you see?
Yes, we can see the slides.
Thank you. Hello, good afternoon. I'm Yongsuk Ko from Konkuk University in Korea. Salamat po, Dr. Victoria Mendoza, for this precious opportunity. In this talk, I will introduce my researches which were proceeded in 2021 to analyze the COVID-19 epidemic in Korea. The researches focus on the early stage of the vaccination and Delta variant, respectively. Okay, here it begins. Okay. So first, I will introduce about the mathematical modeling of COVID-19 considering age structure and vaccination. So this paper is now in journal. So if you want to look for it, then you can check this. So here begins. This is daily administration number of vaccine. Vaccine from 26 February to the middle of June. So currently, we have sufficient amount of vaccine. However, as you noticed, the number of vaccine at the early stage was extremely limited. So amount of vaccine from February to May was almost similar to the amount in June. With this motivation, we proceed the mathematical modeling to deal with this issue. So in this research, we divided population into 4 groups. So there were several statistics that healthcare workers have relatively higher risk of being infected. So we consider healthcare workers. And there are underages, adult, and seniors. As many of you already know, heterogenic group structure, this model requires transmission metrics. So we should know the transmission rate between lahealthcare workers, underage, adults, senior, also the transmission rates among them. But anyway, because of lack of statistics, we don't have metrics for this. However, thanks for the Korean Disease Control Agency, individual COVID-19 case data, which can be used to estimate transmission metrics, was provided. So this data contains age and diagnosis date and symptom onset date and whether a patient is a healthcare worker. So we aggregated the data from October to February 2021. So let beta yx, the transmission rate from group Y to X, then we can, so considering frequency-dependent transmission, homogeneous mixing, and Poisson distribution, the probability of not being infected can be calculated as below. Simply, the opposite probability, which is probability of infection, is formulated as this form. So everyone has probability of infection at any time. So everyone has likelihood from the beginning to the end. So the likelihood is formulated as this form. And this other research, we have observed that the transmission rate among healthcare workers was highest, and transmission rate from adult to adult, was not high as this, but still it was high. But a transmission rate among the seniors was high. So this might be related to the mass infection in daily care centers. And this is so we normalize the metrics. So we observe the relative risk of being infected and transmit disease. So this is risk of being infected, and this is risk of disease transmission. So who will transmit disease more, and who will expose to the disease more? So this is quite obvious. So alert is like a main source of infection, and the healthcare workers, they are more vulnerable to disease than the other groups. So with this matrix, we apply this matrix into the mathematical model, and here is the formula, and here is the flow chart, and this is the parameters for the mathematical models. So, and there is this is based on very classical SIR model, but we added this Q. This Q means the isolated individuals, and this U and V and P, these are related to the vaccination. So this U group does not effectively vaccinated. So this group can be infected, and this V group is also can be infected, but this group has the effect vaccine. So it sooner or later it will has immune to the disease. So this group P has no susceptibility. So here is the fatal rate. So as you can see, the group 4, which is senior, they have relatively higher fatal rate compared to other groups. And for this research, we said the vaccine effectiveness is 86.6%. So by the way, we apply this matrix, but as you know, in each time page, the transmission situation is changing. So I just added this beta 0, which is transmission rate adjusting constant. We fitted this into the data in Korea. So we did simulation from 1st October to 25 February because the vaccination, it began from 26 February. So as you can see, I fitted the beta 0, which is adjusting constant. So the refractive number was like this shape. So as you can see, from 1st October to 23 December, the case was increased, and later, so from 23 December, the private gathering was limited. It's like only 4 people can meet each other. So because of that, transmission rate was quite lower than the other phases. So this is the result of each groups. So as you can see, the most of the case were occurred in normal adult, and senior was next. However, when we adjust it by their population, then we can see that healthcare workers has like a 3 times higher infection number compared to the others. So from now on, we use the state of the final time of the model. So after 26 February, we apply vaccine, but we said that different daily number of vaccine and total amount and effective refractive number. So in each simulation, the vaccine order is different, and also the daily vaccinated number is different, and total amount is different, and vaccine amount by group is also different, and also the refractive number is different because we want to see which vaccination order is effective in each situation. So there are number of scenarios is 120, and also because in each simulation the vaccine order is different, so we set it differently. So there are like more than 1,000 of simulations. 2,880 simulations were proceeded. So here is the result. So from now on, we just focus on which vaccination order would be good in the early stage of vaccination. So this upper graph shows which vaccination order is good to minimize the incidence, and the below graph shows the which order is good to minimize the mortality. So as you can see, the vaccination order for best vaccination order for minimizing the incidence and the minimized mortality is quite different. So, but we focus on the mortality minimizing strategy. So as you can see, if the leapfrog number is below a certain level, it was best to vaccinate the senior and next healthcare workers and adult and underage. So as you can see, in every scenarios, vaccinating underage was like not try underage is not prioritized to be vaccinated, but adult or healthcare worker was the most target group. And when it is focused on mortality minimizing, then vaccinating senior was best if the leapfrogging number is below 1.1. However, if the leapfrogging number is over 1.3, things are changed and others should be vaccinated if this situation is keep going. But if the leapfrog number is more than 1.3, that means it will be very huge. So our model simulation shows that Korean government plan to vaccinate healthcare workers and seniors to minimize mortality. So during the time, so around 26 February, the estimated leapfrogging number was around 1. So we can say that strategy was effective. But anyway, this model simulation shows that the social distancing is very important during the vaccination phase. So this was the result. We focus on the early stage of vaccination. So from now on, currently, because of now in Korea, we have fourth wave of COVID-19, the Delta variant. So from now on, I will introduce you the mathematical modeling of COVID-19 considering Delta variant. So wait. So this this study is now in medRxiv. So hopefully it will be accepted in some journal. So from now on, we focus on the Delta variant, but there are several issues about Delta variant. So for example, if you see this, we can check that the Delta variant had the vaccine effectiveness for Delta variant is relatively lower than the other strains. So for example, the BNT162b2, which is normally known as Pfizer, its effectiveness for the Delta variant is dropped to 88. And also, one of the most important thing is it has like almost twice higher basic leapfrogging number compared to non-Delta. So because of this, we should focus on the Delta variant. So this okay, wait. So this is current situation in Korea. So this orange graph shows the proportion of Delta variant among confirmed cases, and this gray shows the proportion of fully vaccinated people in Korea. But however, as you can see, until middle of July, the social distancing level in Korea, it was 2. But after middle of July, social distancing level in Korea was enhanced to level 4, which is very high. So there was like a private gathering more than 3 was restricted during this time. So, but even with the strong social distancing, the case was increased as the proportion of Delta variant among the cases was increasing. And also from November, so government decided to relax some distancing, which is called a step-by-step recovery. So after that, the case increased again, even though the vaccine proportion of fully vaccinated people are increasing. So in this study, we also applied the maximum likelihood estimation. But so the probability is same as I used before. But in this study, there are like 8 groups of people. So from now on, we don't consider about the healthcare workers. We just divided population by age. So the age from 0 to 18, and age from 19 to 29, and age from 30 to 39, 40 to 49, 50 to 59. So 10 ages each. So wait. Yeah, so the probability is same as before. But for the likelihood, so from now on, we have vaccinated individuals. So there are 3 types of likelihood. One is for the unvaccinated but uninfected, and one which is effectively vaccinated and uninfected, and the one infected. So these infected groups have probability of not infection, and later it will be infected. But the other groups, they survive until the end. So, but in Korea, so because of lack of data, we don't have data that one is infected by Delta or not. So we couldn't distinguish who is infected by Delta or non-Delta. So we just divide the time. So from February 26 to June 30, we said that during this time, Delta variant was not dominant yet. So we can say that estimated transmission metrics during this time is a transmission metrics for the non-Delta. But after August, so more than 80% of cases in August was more than 80, and from middle of August, it increased to like a 95, 99%. So we said that Delta variant metrics is the transmission metrics which is estimated in this page is transmission metrics of Delta variant. So these are the results. So as you can see, there are distinguishable difference, especially among the young age groups. So these young adults, they have relatively higher transmission rate than the other age groups, and also the underages, they have relatively higher transmission rate among the other groups compared to the before. This might be related to the transmission characteristic of COVID-19, because before Delta, the transmissibility of young age group was really low. I don't know why, but anyway, there are several references which say that some underages, they are relatively less susceptible compared to the adults. But anyway, after Delta, it has been changed, so it will make situation differently. So in this phase, we normalize the metrics using the basic reproductive number of disease to exclude non-pharmaceutical interventions. So we divided element by the reproductive number of metrics and multiplying reference basic reproductive number. So from now on, without non-pharmaceutical intervention, our model will make the reproductive number which is identical to the basic reproductive number of the disease. So from that reference, we found that basic reproductive number of COVID-19 is 3.17, and Delta variant is 6.24. So it's almost twice higher. So we apply this metrics into the model, and from now on, we will estimate how government's non-pharmaceutical intervention reduce the transmissibility. So this is the mathematical model. So as you can see, now it becomes more complicated, and there are like a strain of non-Delta variant and Delta variant. And also we want to check the severity. So we divide the isolated group by 2. So this M means mild cases, and this S indicates the severe cases. And as I said before, there are U and V and P, but from now on, P is divided by 2. So there are P full and P part. This P full means fully effectively vaccinated, which means that they are no longer susceptible to the disease. But this P part, they are still susceptible, but only for the Delta variant. So they can be infected by Delta variant. And this is the model. So it becomes complicated, but you might see the same pattern as before. So this is the parameters we put into the model. And this is, so from now on, we apply this mu in each time. So it will reduce the transmissibility in local community. So we estimated how government's non-pharmaceutical intervention reduce the transmissibility of the disease by time. And this is age-dependent parameters in the model. And because in Korea, in each age groups, they have different vaccines. So we set the different vaccine effectiveness to the age groups. So for example, the age group 2 or 3, they are young people, so they got Pfizer. But age group 6, so in Korea, the government decided to give them AstraZeneca. So they have AstraZeneca, so they need more time to be immune. And also they have less effectiveness to the disease. So here is the model result. So, so we said that Delta variant case arrived at 19 April 2021 because the data say that at that time the exposed host they arrived. So as you can see, before the fourth wave in Korea, most of the cases were occurred in age group 5, 6, 7, 5, and 6, the middle age groups. But as you can see, after Delta variant arrived, things were changed. So most of the cases now occurred in younger groups compared to the before. This might be related to the real vaccine in Korea because our model also considered the real vaccination in Korea. So this is the time-dependent parameter estimation result. So this blue graph shows the effective reproductive number, and this orange shows how government non-pharmaceutical intervention reduced the transmissibility in local. So one big difference is here. So before July 12, the level of social distancing was 2. And after July 12, social distancing level was enhanced to level 4. And estimated this reduction factor in this phase was from 0.64 to 0.70. But during the time the social distancing level was 4, it was estimated from 0.70 to 0.78. So we can say that social distancing level 4 has higher effect compared to the social distancing level 2. So this might suggest kind of how government's policy effect. So this is our forecast, which was started from 8 October to the end of this year. So we want to see it gonna be possible or not. And we said that when government decide to ease the distancing, so these colors indicates when it will begin, and the shape will shows how it will be eased. So the red curves, these are the assumption that the social distancing is eased right after 8 October, and dark is 18 October, and blue is from 1st November. Actually, the government decide to ease it from November 1st. However, it will be already eased a week ago because there were like several changes, like a number of private gathering or opening of the stores. They changed it like a week before the 1st November. So, and this red squares indicates the real data, and shape of the curves indicates how much it will be eased. So solid curve indicates the even though government is the distancing policy, but it will be still people are still what if they just act like during the time social distancing level was 2. And also this dashed graph is also identical to the social distancing level 2, but like a lower bound of social distancing 2. And this dotted line indicates if government decide to ease it, then people just act like it was social distancing level 1, which was estimated in last year. So the Egypt policy is close to this. So as you can see, the real data follows between this the dark dotted line and blue dotted line, because people they already be Egypt a week before. So as you can see, it follows. But however, recently the data it is over our estimation. So it's because in this study we did not assume the vaccine waning effect, but in here there are several researches about the waning of the immunity after vaccination. Because of that, it might be higher than our forecast. And this is the maximum number of sick beds for severe cases in Korea. So this is also increasing now because government decide to make more sick beds. So in this forecast, we found that it might be not exceed, but currently it might be really dangerous. And in Korea, for example, like from this week, so social distancing is enhanced again. So this is forecast for the cumulative deaths. So from now on, we generalize the model simulation. So not forecast, but we just said that initial condition is identical to 26 February. But we also fixed this reduction factor ranged from 0.52 to 78. So we want to see which simulation can show the good result. And also we set the timing of arrival of Delta variant infector. It can be ranged from 0 to 80. But in Korea, so because April 19th, so that is T Delta was 52 in Korea, but we changed it so from 0 to 80 to see how it really happened. But in this approach, we just fixed the number of vaccine for the population as 40 million, but with a different speed. So it's like what if the vaccination was finished within short time, and what if vaccination is delayed? So we will see how they will affect. So this is one of the example. So we just fixed the reduction factor as 0.67. So we just said that social distancing is level 2. But we also said that the timing of Delta variant infector arrived as 52, which was in Korea. But there are two different vaccine speed. So one is 200,000 per day, and one is 400,000 per day. So this blue is when the vaccine daily vaccination number is 400,000 per day, and this red is 200,000 per day. But as you can see, if the vaccination was fast, then there will be no fourth wave. And this situation shows the fourth wave. So it's like, depending on the number of vaccination, there will be second wave or not. So this simulation result shows that the vaccine is important, and also vaccine should be administered faster as it can. And next is we did 1,000 of simulations with different value of the timing of Delta arrival, and also the reduction factor, and with also different daily vaccination number. So this upper line, upper graph shows the confirmed case number, and second, death, and third, peak number of severe patients. And this red line is maximum number of sick beds for severe cases. So if the number of severe cases reaches more than this, then there would be medical collapse. So we can say this area is safe and this area is dangerous. So as you can see, as vaccination speed is fast, this safe area becomes wider. So for example, what if the Delta variant infector arrives 14 days after the simulation with social distancing level 1, it still be fine, but in this case, it's not fine anymore. So this model simulation also shows the importance of fast vaccination, but also the importance of these screening measures in airport. So what if Delta variant came earlier, much earlier, then even with the fast vaccination, there would be medical collapse. And also social distancing is also important. So it shows that at least social distancing level remain as level 2 or level 1. So this is discussion and conclusion. So transmission rate of non-Delta and Delta variants show different pattern, especially for the younger age groups. And also we quantify the effect of simultaneous interventions and vaccination, and effect of social distancing was quantified. So in level 2, the reduction rate was estimated from 64 to 70, and when the level was 4, it was estimated the effect was 70 to 78%. So updated data were in the range of prediction. Unfortunately, it became not recently, but it might shows that in our next project we should consider about the vaccine waning effect. But still, this model simulation showed that such as social distancing or like prompt administration of booster shot would be necessary to minimize the cases and deaths and severe patients. And this study emphasized the importance of all interventions, vaccine, social distancing, and screening measure. So an epidemic wave can be avoided if a strict social distancing policy is not relaxed too early. And also outcomes may change depending on vaccine administration and emergence of a highly transmissible variant. So thank you for listening.
Okay, thank you very much. Let us all give Yongsuk Po our warm round of virtual applause for that nice talk. Thank you. Okay, so the floor is now open for some questions. So actually, I have a quick question. Could you, I don't know if I missed it, could you describe the different social distancing levels? So is it a policy in Korea, these different levels of social distancing?
The policy is different. So for example, if the social distancing level is 4, then the stores in the street, they closed much earlier, like 9 p.m. But during the time when it was 2 or 1, they can be opened until like midnight or 11 p.m. And the main thing was different, is especially for the private gathering. So for the private gathering during the level 4, maximum was 2 after 6 p.m.
Okay, thank you very much. So we have a question here on the chat. In the first study, you propose a vaccination prioritization strategy in Korea. So the first question is, did the Korean government implement a strategy similar to your proposed strategy?
Yes, actually, so our study showed that it was effective because that time, because of the social distancing, the number of cases was not that high, and also with that situation, so we can apply the vaccine to the elderly and the healthcare workers. So our model simulation showed that it was effective at that time. And the second.
And second question is, thank you. So second question is, your method was applied in Korea. So what modifications should be done if you want to apply the method in other countries, for example, in the Philippines?
So for example, for the Philippines, I think unreported cases should be considered, because in Korea, most of the cases were found because there were like a mass, like a lot of tests. So we assume that there's no unreported cases, but I heard that in Philippines there were like a lot of unreported cases. So for the Philippines, it should, I think the unreported cases should be considered.
Yeah, okay, thank you. Do we have other questions from the audience? Yes, Sir Ernie, Dr. Lope.
Hello, good afternoon. I must have missed it, but I noticed that in Korea you have several vaccine brands. No, you have Astra and you also have Pfizer.
Yes.
And in the very last model that you showed here, all right, and you claimed that in the last model, you claimed that the wave could have been avoided if if vaccination was done earlier. My question really is, how did you treat the effectiveness of the different vaccine brands? Because as you've mentioned, like Pfizer would be far more effective than Astra, and Astra takes a long time, no, for the immunity to set in. But I wasn't able to see that in the model, no, how the efficacy rates were taken into account.
Yes, it was we have a data of how many number of AstraZeneca and Pfizer were administered to each age group. So we can like normalize the effectiveness to each age group. So with this, for example, the like age group 6, they have relatively lesser effectiveness to the disease.
Okay.
Yes, we got the data, so we just use the data to estimate the vaccine effectiveness to each age group.
I see. Okay. And sorry, I must have missed it. So in a single age group, there's only one brand.
This is not single age group. So this is also group dependent model, but I just want to show the total number. So this is age dependent result.
No, my question really is in Korea, do you give out different brands for the same age group, or is it clearly delineated? Let's say if you are 35 years old, then definitely you should be Astra. You can take Pfizer or something like that.
It also depends on time. So
I see.
So people like before August, even 20s, they can get AstraZeneca that time, but government decide not to give them AstraZeneca from July or August. So everything is depend on time. So all we have to do was just use the exact number of vaccine into the each age groups.
I see, but it's very good that you have good data, no?
Yes.
Yeah.
Last question.
All right. Very last question. Anyway, you're showing the graphs. Could you go back? I think 2 slides. No, further. Oh, I'm sorry. This graph, right?
Yes.
Could you offer any possible explanation why the model overestimates the what is this, confirmed cases for the
age group
60 to 69? Yes, it's fairly overestimating the data, no, compared to the other age groups.
Yes, it's because one of the reasons it might be related to the AstraZeneca. So I said a relatively lesser effectiveness to age group 6, but maybe, but I'm not sure. Maybe we overestimated the transmission metrics for the age group 6, or maybe we underestimate the vaccine effectiveness, or maybe vaccinated individuals, they might don't go outside or something like that. So I think that might be the reason. So,
all right.
Yes.
Thank you.
Thank you.
All right. Bye.
Yes, thank you very much. And we have another question from Dr. De Los Reyes. So, Sir Au.
Hi, Young Sok.
Hi, hi.
Thank you so much for your presentation. I have a couple of questions regarding the method itself. Like, for example, why did you use Poisson and not any other distribution? Because the likelihood will change, for example, if you use negative binomial. Is there an advantage of using Poisson over other distribution?
I didn't try other distributions, but I just assumed the Poisson distribution because this is relatively more simpler than the others. So that's all. I need to consider about the other distributions,
Yeah.
about the likelihood.
Yeah. Okay. And when you set up the first model with the healthcare workers, so you actually distinguish healthcare workers. So you did not consider the age. So there, I was thinking there was an overlap between 19 to 64 and the healthcare workers' age.
Yes, actually, we excluded this number of population from the others. So these healthcare workers, of course, they are othered. They
Okay.
should not be underage. They should not be
Senior as well. Okay.
Yes.
So, but it's distinct from your adult 19 to 64.
Yeah, they are extinct.
Okay. And it has something to do with the waning period that you already mentioned.
So waning effect. So for both of the study, we did not consider waning, and especially for this study, we did not. And also for this study, it was our we were focusing on the early stage of vaccination. So it was just for 100 days. So we did not consider like a year. So that's why we did not consider the waning effect.
My question is about the effectiveness. Like, how do you measure the effectiveness of the vaccine? It's not on this study, in the second study. So you have like values for the effectiveness.
Yes.
How is it measured from the data? Like, do you look at the reinfection, or how do you measure the effectiveness?
So for the effectiveness, we just use the references. So we use several references from the I forgot the name. It was a New England. It was a research paper in New England Journal. So if you are if you're I can send that to you.
Yes,
yes.
Yeah. Thanks. And so regarding the matrix between the healthcare workers and the other groups, I did not see. Yeah. So in the lower graph. Okay. So what does it mean? Because for example, I can only see the red and the blue says to other groups. Does it mean to other age groups like underage, adult, and senior? Like the blue one.
So you mean this one?
Yeah.
So in this. So in this one, the left shows the risk of this disease transmission. So this it might be confusing. I'm sorry about this. The red means the risk of this disease transmission to same group. I mean, so for this is like a risk of transmission from other to other.
And how did you compute that risk?
So we use the number of population of each group and this transmission metric. So this is like a adjusted value for each groups.
Yeah. And I'm just wondering regarding your second model wherein you considered 8 age groups. I could see that you have information on the vaccination and efficacy and so on, but do you think it would be because I'm thinking it would be easier to analyze if you have lesser age groups than 8? Like for example, for the as you considered in the previous study, you can consider only those from 60 and above, and probably you can lump 40. I don't know. I'm just thinking 40 to 60 and the rest.
actually, we really wanted to make it simpler, but unfortunately, the age-dependent data is this age group data. So that's
Okay.
why, yeah, that's we want to really. So for example, we want to just set preschooler and school underage groups, and we can just merge like a like a like a age from 18 to 40 merge into just one adult group, one young adult group, something like that. So
Yeah.
we can do that in future,
Yeah.
but during this time, our data was like this age structure is just this age structure we made it because the data is for this.
Yeah, because I noticed in your model when you set up this compartment model, you also have for the isolation.
Yes.
You also have isolation for the severe and mild. Is it really implemented like in the hospitals? Like, do you really separate those who are with mild cases? Is that in the hospital case or a home quarantine? What does it mean? Mild and
So
severe.
severe. So this severe, all of them are in hospital. But this mild, they might be their home or they might be in some some facility for isolation. So,
Okay. So these are
but
not the same. Okay.
yeah,
So
they are not in same place. But
okay.
these severe patients, they are in hospital.
Yeah. And sorry, I have a lot of questions, but one more,
That's
one
okay.
last more. It's
Okay.
it's the reduction rate because I could see it from here. Yeah, the U of T.
Mhm.
I noticed that you estimated it. Is that weekly estimation or every 2 weeks?
Not every
I
week.
I saw the I saw the piecewise
Mhm.
reduction. I think it's your next slide, I guess. Yeah, this one.
Yes, we
So
just
how did you divide it?
it was based on the police change.
Okay. Okay. Yeah, that
Yeah,
makes
police
sense.
change
Yeah.
and also so if one phase is just wrong, then we just divided it. So but such as this, but actually it was very similar. So
Yeah.
actually I didn't have to divide it.
And based on the policy, it's you who decide like if the reduction is within this range, then it's social distancing level 1, 2 to 4. Is that right?
So in this, yes, we it's like a suggestion of a range of reduction by different policy. So in level 2, it was range from 70 to it was ranged from 64 to 70, and during the time social distancing level was 4, it was a range from 0.70 to 0.78. But when the effect was more or less, as you know, this time there was holiday in Korea.
Yeah, because I'm just confused. Like during the social distancing level 4, that level towards the end, it's almost the same as the one in social distancing level 2. Is it not?
You mean
Yeah,
this
that
value?
one. And then if you look at the social distancing level 2, yeah, that
Yes.
one.
It's one of the main reason was during this time there was there was Chuseok in Korea. It's like a
Okay,
Thanksgiving Day.
I
So
see.
because of that people gathered a
And there's
lot.
a lot of gatherings.
Yes.
Yeah. All right.
Even with the social distancing level 4 and government. So this time they reduced a bit. So they just let people to meet their family.
Okay. Yeah. Thank you so much, Youngsak. Thank you.
Okay. Thank you.
Okay, do we have any other question? Okay, so if there are no more questions, again, we would like to thank Young-Ko for giving this nice talk, and let us give him once again a warm round of virtual applause. Thank you very much for sharing your research with us. We appreciate it very much. And we would
Salamat
like to,
po.
thank you. And we would also like to thank everyone for attending and listening. So this is the last IMath webinar for this semester. Okay, so we will be, so the next one will be in the second semester of this academic year. Okay, so again, thank you very much, Yongsuk, and to all those who attended, and we'll see you again next time. Okay, goodbye. Thank you.